once again for joining us here, real-time live streaming as part of the 19th Bangkok International Symposium on HIV medicine. My name is Petchsri Sirinirund. Now I'm joined here by Dr. Nittaya Phanuphak, the Chief of the Prevention Department of the Thai Red Cross AIDS Research Center. Sawadee ka. Thank you very much for joining us. Now you just came out of the symposium of the conference room inside and you had a presentation regarding testing.
Yes.
But before that, do tell us more about the role of the Prevention Department.
Prevention Department is one of the units under the Thai Red Cross AIDS Research Center, and the main activities that we are doing is to do research to inform the policies at the country level, and that's why the test and treat is the key or the core component of the research studies that we have been doing. And when we talk about test and treat, that does not only mean that we are talking about HIV, because when you are taking care of a person, it's a whole person that you are taking care of. So we are also looking at test and treat model for other diseases that is related to the populations that we are working with as well. For example, for men who have sex with men, gay men, we are talking about human papillomavirus, anal warts, something like that as well. And when we're talking about transgender women, we are also talking about hormone therapy. We talk about people who inject drugs. We are also talking about hepatitis C, which can also use the same model of the test and treat.
Now, testing, that's extremely important. It's possibly, if you can say, the first stage, isn't it? So you need to get tested before the treatment can happen, and proper diagnosis, etc., so that the correct drugs can be administered, etc. Tell us about the main parts of your presentation that you delivered earlier regarding testing.
Yes, we now in the era that we have a very effective treatment, we have a very effective prevention interventions, but the gateway into the program, to the service, is certainly the HIV testing. And we know that HIV testing is one of the key target set by UNAIDS, that we will need to reach 90% testing among those who have HIV, that they need to know their status until we can control the HIV epidemic. And we know that by having like conventional HIV testing center, you may be able to reach just a certain group of populations, but how can we think of the innovative ways to get people into HIV testing? That's a key question at this time. The work that the Thai Red Cross AIDS Research Center and also with many other partners in the country have been doing over the past few years is to identify alternative models, such as the use of the community-led health services model, so that we give the roles of testing to the members of the communities who understand the lifestyles of their own community and can design the services that fit perfectly into the lifestyles of their own communities. That's one thing that we can do. The other thing is that many people may still don't want to come out even to the community-based organization to get HIV testing, but they may want to do HIV testing by their own.
Are there at-home kits?
Yes, so we are talking about home testing, we're talking about self-testing, and there is so much potential for these testings to be adapted and then used for different populations.
Right. Yeah. So that's great to hear that there is actually now an alternative to actually visiting the local doctor or the clinics at home. You can actually do it at home.
Yes.
Right. Are there any other challenges when it comes to testing? Perhaps far-reaching areas, remote areas. What about them? Are they left behind, or have they fallen off the grid?
Over the past year, Thailand has seen a very great success in using the community-led health service model, that we can almost double up the number of HIV testing in our country among gay men and transgender women. So it's time now that this year the country will be exploring further whether this model can also be adapted to other key populations, such as people who inject drugs and female sex workers as well. So I think that's there's a great potential for the model to be expanded.
Right. Okay, let's move now from testing to the treating part. Tell us the latest regarding treating.
Yeah. I think that the availability of many effective ARV drugs or ARV regimens is not that very exciting. The more exciting questions is whether or not we can link people who are newly diagnosed with HIV to immediate ART. And we heard from Professor Hafler this morning that same-day ART is possible. And could that be possible, and could it be scaled up in our region, in our country, in our city as well? The research that we have been doing over the past 2 years, comparing people who are diagnosed in the clinic, in a hospital setting, and comparing those who are diagnosed through the community-based organization, has shown to us that it is effective in both models to link more than 85% of people who diagnosed with HIV to receive immediate treatment within a median time of less than 15 days.
Yes.
So I think that's the major step. And the next step is how to retain people who started on treatment to be on treatment lifelong. That's the role that we think that the community-based organization can certainly play a huge role here, because with the burden of the healthcare workers in hospitals, in the communities, of providing cares to people most in need, they don't have enough time or energy left to try to retain people into care. But the communities certainly have a more understanding and more skills to help with retaining people.
Right. Now, time is extremely important. We were talking about same-day ART, which is very, very important, and that you need to get that medication consistently. Now, what about the costs?
The cost of ART, if you are asking about Thailand, it's not the problem, it's not the concern, because every Thai national can get free ART regardless of their CD4 count, and that can be ART lifelong. And it's not only the drug that is free, it's all the lab monitoring and also the safety monitoring that is free as well. The problem here is that we have enough resources to provide ART for everyone in the country, but that how we can really get those who still don't know their status to come out for HIV testing and to link to care. So the cost may not be the problem, not the real concern.
Well, that's really good to know that the costs will not be an obstacle to people getting a better life despite being diagnosed with HIV or being HIV positive. So it's extremely crucial, extremely important to reach out to people, get the news out there, and have people who are at risk of getting HIV to get tested. Thank you very much, Dr. Nittaya. You're going to still be here because you're going to now put on your co-host hat and help me with the next gentleman who is going to come in and tell us more about how to implement PrEP successfully. Let's now welcome here Dr. Andrew Grulich, the head and professor of the HIV Epidemiology and Prevention Program from the Kirby Institute for Infection and Immunity in Society. Sawadee ka. So make way for you there. Thank you very much for being with us today. I know you've got a busy schedule inside. You don't want to miss out on the presentations inside the room as well. But yes, let's go straight into this. Give us an overview of your presentation.
Okay, so I was talking today about pre-exposure prophylaxis, which is one pill once a day to prevent HIV infection. So it's a reduced dose combination of the drugs we usually use to treat HIV infection. There's been years of research in this area, and it is very, very highly effective in preventing HIV transmission. But where the field is up to now is about really implementing it at scale, so to communities at high risk of HIV, to really try to disrupt HIV epidemics. And the goal is really to turn the epidemic down. You know, we've got increasing epidemics, particularly in men who have sex with men throughout the Asian Pacific region. And the goal is really to bend that epidemic and to work towards the end of HIV.
Right, and it's actually about educating the people out there as well, so that they are aware that there is this PrEP in existence which can help to prevent them from getting HIV.
Yes, and we have heard from Professor Grulich that the expansion of PrEP in New South Wales has been very successful. People are getting into the service very quickly, and I would like you to comment a little bit more on the key to the success of that EPIC New South Wales program.
Yeah. So what we've been doing in the EPIC study is rolling out pre-exposure prophylaxis to all people at high risk of HIV. And in New South Wales, that's mostly gay men, but in other settings, it might be other people like sex workers, serodiscordant couples, other populations. I think one of the keys to our success is that we've managed to convince our government and policymakers just how effective PrEP is. And this really can't be overstated that PrEP is probably the best new technology we've ever had to stop HIV infection that can be used by HIV negative people. So it's not for everybody, it's only for people at high risk of HIV infection. One pill once a day, low toxicity, it's really at one level pretty simple. The complexity is building the systems where people at high risk will come forward, and we really need to work with these communities to make sure that that's the case. So we just can't, open a clinic, put a sign up and say, come.
Yes.
We need to work with these communities to publicise this therapy, to make the communities realise how serious HIV is, but there's something they can do, one pill once a day, to stop them getting HIV infection.
It's key indeed. Actually, there is a session that's happening later on today addressing stigma and discrimination. Many people are very, very worried about the stigmatization that they will have to face. And so therefore they fear going out to get help. But it's so important indeed to get help and treatment so that you're not spreading it and that it's contained within you and that you end up living a better lifestyle as well and you better understand it. Right. Did you have any further questions?
Yes, I think that stigma discrimination is key to any program. It's not only HIV testing or HIV prevention program, but also HIV treatment program as well. And we actually have heard a lot of great things, great activities, great campaigns addressing that stigma and discrimination in New South Wales. Would you like to share a little bit more on how come it has been so successful in the communities?
Yeah, so look, I think a large part of it is that community-based organisations in Australia are leaders in the HIV response. Government recognised very early on that working in matters of sexual transmission, gay men, sex workers, all of these things are highly controversial, and governments find it difficult to work closely and collaboratively with those groups. And a far more effective approach is to set up community-based organisations, government-funded community-based organisations. Those organisations still have to report to government. They have to report back on how they spend their funds, and their task is to work in reducing HIV risk and vulnerability in their population. So it's not like they're given, some people fear that if you fund community-based organisations, they'll just go off and waste money. But it's not like that at all. They're very responsive to government and to other stakeholders, to academics, to clinicians. It's a real partnership response. And community is vital because we are dealing with stigmatised communities, and it's just far more productive to work with the communities so that they can educate their peers to help reduce vulnerability.
And we also have heard a very bold statement from you that when we talk about PrEP as one of the HIV prevention methods in the combination HIV prevention package, and you're saying that PrEP has a higher efficacy for HIV prevention than using condom. Can you please explain a little bit more?
So I certainly will, but before I do, I want to make sure that it's understood that I'm not saying we should stop using condoms. Because
continue to use them.
Absolutely. Many people find condoms to be the best, most convenient method of HIV prevention, and that's fantastic. But condoms do break occasionally, and there's a substantial minority of our population who have trouble using condoms all the time. We still get 2 million infections a year in the world, and many of those are infections of people who have access to condoms but they just can't use them all the time. PrEP is very, very highly effective for those people. So in the clinical trials, as long as people take PrEP daily, they don't get HIV. It's close to 100% effective, and particularly so for men who have sex with men. It appears that PrEP is actually more effective in preventing anal transmission of HIV than it is for vaginal. It is effective and highly effective for women. It's a little bit more susceptible to missing the odd tablet in women as compared to men.
So if we are going to tell to the people out there, if they are interested in PrEP, what would be your criteria, risk criteria that you would like to suggest that you probably are the potential PrEP users that should come out for?
Sure. So look, the first thing to say is that PrEP is not for everyone. It's really to be targeted at high-risk people. The World Health Organization suggests that we target populations which have an incidence of 3% or greater. In most Asian countries, that means high-risk men who have sex with men. In some places, it also means sex workers. In limited places, it means injecting drug users, although in most places we hope that access to clean injecting equipment reduces their risks without the need for drugs.
Right.
So really, it's an intervention for these key populations. In the general broader community, in general, with the exception of serodiscordant couples, where one's positive and one's negative, in general, HIV isn't common enough to justify the use of PrEP. So we really, that again highlights how closely we need to work with community organisations, with organisations of gay men, of sex workers, to implement PrEP.
But how will they know that their communities have the incidence of above 3%?
Yeah, well, this is where the partnership approach is the way forward. So, we have researchers who know these data because we have surveillance systems which can tell us where the epidemic is in various countries, and we really do need in each country to know our epidemic. And with that knowledge, we work with government and with community organisations to provide the targeted publicity. Just putting out broad-scale messages to everybody isn't really what we need. It needs to be targeted.
Thank you so very much indeed, Dr. Grulich there. Now, don't forget, for high-risk people, PrEP can be very, very effective, but it's not for everyone. And so we're still going to rely on those condoms. That's the very basic and first stage. So everybody have safe sex and use those condoms. Thank you so very much indeed. That was very interesting. The latest advances in HIV research and treatment. ขอบคุณค่ะ Dr. Grulich there. We are now going to continue, and what we are going to discuss next is focused on gay men and what they need for effective HIV prevention. So we're going to bring on Mr. Benjamin Bavinton. He is the project leader of Opposites Attract at the Kirby Institute for Infection and Immunity in Society at the University of New South Wales. Sawadee ka.
Hello.
Welcome.
Thank you very much.
Thank you very much for being here. So do give us an overview then on your topic here. We're going to now focus on gay men. Now that came up a lot because they're actually high-risk people, aren't they?
Absolutely. So the first thing that I focused on was really making the case for why we need effective HIV prevention in gay men, and that's really looking at the epidemiology around the world, showing that even in places where we're seeing some stability in HIV infection rates overall, or we're seeing decreasing prevalence in the general population, amongst MSM and transgender women as well, we're seeing increasing rates. So clearly something more is needed. We need to be thinking about the package of services and the package of prevention methods and the way that we actually deliver those to be more effective.
Correct. Then that we have to reach out to everybody and not just certain groups, certain people. Yeah?
Absolutely. Within the gay community, I think a lot of people think about MSM or the gay community as fairly homogenous, that it's just this group of people that you can go to one organisation and they can just access them all. That's not at all how the gay community is structured. It's made up of lots of little subgroups, lots of different networks. So it requires a really sophisticated response to really and sophisticated set of networks to really reach all the people that need to be reached with the messaging and the invitation to come in and access prevention services.
Okay, so straight into the question then. What do gay men need to do
Okay.
to prevent themselves?
So I just talked for half an hour about that, but it
Yes.
basically breaks
In a
down
nutshell,
into...
you have about 5 minutes,
Yes,
please.
breaks down into about 4 things that I was talking about
Okay.
today. The first was access to HIV prevention tools. We've got the methods. We know what works. PrEP, treatment as prevention, condoms, and a range of other risk reduction strategies that gay men can employ at different times that have different types of safety. So people need to have access to those. Secondly, they need to be educated about them. You can have as much access and affordability and convenience as you want, but if gay men don't know about the methods, particularly the new ones, then they're not going to be able to use them. In that context, what we need is really culturally appropriate HIV messaging that is primarily done in a peer-based way by gay men for gay men. That is going to be the thing that is the most successful way to reach people with educational messages. Part of that is also appealing to people's motivations for wanting to stay HIV negative and their motivations for not wanting to pass on the virus if they are HIV positive. So it needs to get a little bit more complicated than just providing information. It needs to start talking to people about a call to action. What are we actually trying to do here as a community? We're trying to end HIV transmission. So that was the second component. The third was around making sure that we have a supportive institutional environment. So this is about funding. The MSM response around the world is chronically underfunded. So there's really not enough money going to these programs. Even though the prevalence and incidence is higher amongst MSM than general populations, most of the money goes into general programs rather than targeted programs. So we need more money. And some of that money, or a large proportion of that money, needs to be spent on community-controlled organisations that are built within the community themselves, that have the authority of the community, that are trusted by the community, and that can reach out through their networks to lots of gay men. And then the final thing that I talked about today was having a stable and good, solid foundation of HIV research. HIV research among gay men has been absolutely vital to any successes that we've had in HIV prevention over the years. And so we absolutely need that to continue. And in the Asia Pacific, we also know that there's many countries that actually have hardly any or no epidemiological data and no behavioural data about what gay men are actually doing and who's at risk. So we really need to increase that situation as well.
Okay. So 4 key things here, and that is 1, access to HIV prevention tools. 2, you need to know how to use them. So you need to educate people out there to get updated, especially on the latest as well.
That's right.
And a supportive environment. And more money is needed. So what can we do to inject more money into that area as well? And finally, a stable foundation, which means to continue with research so that we come up with more solid ways to prevent, to treat, etc. All right. Any further questions from you, Dr. Nittaya?
You mentioned about the community-controlled organization. This is not a very common term that we heard about. You probably must be named community-controlled organization. How is that different from the community-based organization?
Yeah, there's really not a huge amount of difference. It's a word that's, community control is a word that's starting to emerge in Australia. We've always used community-based. But now the organisations who are genuinely community-controlled organisations are feeling they need to make their case a little bit stronger to funders and to government and to other partners in the partnership to really show this is not just about being based in a community, this is actually about the community controlling everything that happens in that organisation and gaining their authority from that community to be able to speak, their expertise.
That's very important.
So it is important.
Because in New South Wales, you are in a very unique position that this community organisation are fully funded by the government, and there may be question whether the government will then control the community-based organisation. Yeah. So how was that balanced?
That is a difficult balance, mostly because we have a very strong partnership approach in Australia. The governments provide the funding to the organisations and mostly just trust them to get on with it and just do the right thing. There is obviously sort of reporting and monitoring that happens, but it's pretty minimal. They're trusted as a partner in the response rather than being constantly checked up on. So the idea about moving away from sort of community-based and community control is that even in Australia, we are moving into an environment where funding becomes more competitive and it becomes more difficult to convince stakeholders that they need to retain the high levels of funding that we've been so lucky to have. And so using terms like community control rather than community base helps us to make that case a little bit stronger.
I see. Okay. Well, good luck with everything there, and we do hope to hear more and more good news regarding that, and hopefully this group that you were talking about, gay men, will not be sort of falling through and being left behind or left out from the latest. All right, thank you very much indeed for coming in to share with us, Mr. Benjamin Bavinton, project leader of the Opposites Attract at the Kirby Institute for Infection and Immunity in Society, University of New South Wales.
Thank you very much.
Thank you. Thank you very much. Dr. Nittaya, we thank you so much as well. Thank you very much indeed. And now for all of you joining us, we are real-time live streaming here for interview sessions, one after the other, latest advances in HIV research and treatment. I would like to now bring on here Dr. Donn Colby. He's a physician at the Thai Red Cross AIDS Research Center. So let's welcome Dr. Donn Colby up here. You are going to be joining me as co-host.
Yes,
and
I will.
helping extract all the latest information and revelations, etc., from our guests. We will now continue to talk about policy and 1990 strategy, and we are going to be talking to Dr. Steve Kraus. So let's welcome Dr. Steve Kraus, the Director of UNAIDS Regional Support Team for Asia and the Pacific. Sawadee ka.
Sawadee ka.
Please take a seat. And thank you very much for being with us. First of all, let's talk about this 1990 strategy. Can you give us an overview on what that is, please?
Sure. I mean, I think a lot of the audience may know this already. We're certainly talking about a lot today.
Yes.
90-90 is really two things. It's about treatment. About 90% of people know their status, whether they're HIV positive or not. Then those who are positive, 90% receiving treatment. We have highly effective treatment today, so 90% receiving treatment if they know they're positive. And then those that receive treatment, 90% of them are immune suppressed. So 90% knowing their status, 90% accessing treatment, 90% immune suppressed. The second 90 is also about prevention. It's about making sure that 90% of people know their status, 90% reduction in the numbers of new infections, and a 90% reduction in discrimination.
Right. Now you're going to be delivering your presentation later, in actually about half an hour from now.
That's right.
Can you tell us some of the key points that you will be sharing with the delegates and participants? Is that possible?
Sure, absolutely. I think that a lot of the speakers this morning were just spot on. They captured so many great ideas. I thought one of the things that Nittaya mentioned in her talk, we know what to do on treatment and we know what to do on prevention. We just have to kind of, in a sense, have the energy to move that agenda forward and not waste time. If we are going to end AIDS by 2030, the answer is not, well, then what do we do at 2025? The answer is being written today. If we're going to end AIDS by 2030, what are we doing in 2017 to end AIDS by 2030? Because these 3, 4, 5 years are crucial. If we don't succeed in the next 3, 4, 5 years, we won't end AIDS by 2030. So the time to act is now, not later.
So more money being injected into R&D, and the experts have to work even harder, because now is very, very important too. Dr. Colby, anything else to add there? Is that any other highlights from your presentation?
I have another question for Steve, and that is because I know UNAIDS has set some very specific goals for the next 3 years, just now through 2020, which is only 3 years away. Maybe you can give us a preview of what those goals are in the next 3 years for the region.
Sure. Well, member states gathered in June of 2016. They gathered at the United Nations in New York, and they agreed on a global strategy. But for the first time, they agreed on regional targets. And so, for in our region, we want to drive down the numbers of new infections from 300,000 a year to 90,000 a year. We want to make sure that people who are accessing treatment today, 2.1 million people, we want to increase that to 4.2 million people. So driving down to 90,000 new infections from 300,000, increasing 2.1 to 4.2 million people on treatment, and then we want to see a 90% reduction, actually a 100% reduction in stigma and discrimination. But for 2020, we're saying we want to see a significant reduction in the discriminatory laws, policies, and practices that penalize people for being who they are.
That seems like a very optimistic goal, decreasing new infections by 2/3 in the next 3 years. Do you think it's feasible to get to that goal? And what do you think were the key activities you would need to do, or the region and the countries in the region need to do to reach that goal?
Yeah, I thought a little bit of the answer to that, Don, was given this morning, is that find out what you can do in your own setting and then go do it. Don't wait for everybody else to catch up. Find out what it is in your, not only in your country, but in your province, in your local community, about where the infections are taking place and what you can do today to make a difference. So we've got the technology for prevention. We know, for example, that PrEP works. We know that community testing works. We know that home-based testing works, that more people will know their status. We know that ARVs protect lives. But how do we get more ARV into the community? How do we deregulate the environment that somehow prevents us from doing the creative community work that needs to be done? So I think that those are the challenges we're facing. And then again, just let me repeat, I think that what we've done in some countries where we're seeing great treatment scale up, including Thailand and Cambodia and in Myanmar, we have seen a reduction in the legalization or the criminalization of specific behaviors. So when we decriminalize same-sex behavior, when we decriminalize commercial sex, when we decriminalize drug use, we make important policy progress to ending AIDS by 2030. The criminalization and the criminalization of human behavior does not work on a public health basis. We just put more people in prison, we put more people on the streets, and we isolate them from good healthcare services.
Wow, wow. So that was very, very interesting. I'm still trying to take all of that in, and yes, I think it's ambitious indeed to reduce this regional target from 300,000 down to 90,000 and perhaps even fewer. What are some other key points which you would like to bring forth to the audience joining us live right now?
I think one of the fantastic things about working in Asia and the Pacific is the creativity that you can find in this region. We have superstars all across the region, and you've interviewed so many of those wonderful people this morning and this afternoon and tomorrow. I think we just need to harness that energy, that creativity, create the political space for them to do that, and then to applaud them and to affirm them, because these giants, these innovators, these provocateurs, they need to be supported, not punished. They need to be rewarded and affirmed in their professional careers and in their political careers, that they are doing not only the brave thing, but the right thing, and affirm them to make that kind of behavior. It's difficult for any political leader sometimes to associate themselves with minority populations. Yet that's what we have to do in the HIV/AIDS. We talk about the sustainable development goals, that no one is left behind. That's what I have to do here. Make sure that no one is left behind. Right. And I think we see leadership coming from countries in this region to make sure that no one is left behind.
All right. Thank you. Thank you. Any final questions from you, Dr. Colby?
No more questions.
All right. Perhaps questions for our next guest, but we have to thank you so very much indeed. And I know the participants and delegates are really looking forward to your presentation later on. Unfortunately, I can't be there myself to hear from you, but perhaps I can go online and check it out later. Thank you so very much indeed for taking the time to be with us. Dr. Steve Kraus is the Director of the UN/AIDS Regional Support Team for Asia and the Pacific. Thank you. You might want to get ready now for your presentation, as I know it's one after the other, and you've got about 15 minutes to prepare for that. Thank you. Thank you. Khop kun ka. Thank you. All right, we are now going to continue here. You're going to still be here.
Yes, I am.
I need you here, Dr. Colby. We are going to move on now to the national setting. Thailand. Focus on the efforts being put into reducing the number of new infectants, if you will, and also the latest advances, what's been happening here in Thailand. We would like now to invite Dr. Petchsri Sirinirund, a consultant from the Ministry of Public Health, to join us here. Dr. Petchsri.
ค่ะ
สวัสดีค่ะ
สวัสดีค่ะ
Please
สวัส
do
ดีค่ะ
take a seat. Be careful. It is a bit slippery here.
Slippery,
We don't want you to fall over. Plus, the chairs move a little bit as well. They bob up and down as well. So do be careful right there. Now, as I earlier mentioned, we are going to be focusing now on the Thai context. Right, and you will also be making a presentation later on inside the main conference room as
Yes.
well. So can you give us an overall picture of the situation here in Thailand to start things off, please?
Yeah, actually, following Steve Kraus, in Thailand, currently the new infection is expected to be around 6,000 people per year. But for our goals, we would like to be less than 1,000 per year in 2030. So the new infection in Thailand is declining.
So it is declining from 3,000 a year you mentioned just now.
Now, currently is 6,000.
6,000, sorry,
yeah.
6,000. And you want to reduce that down to 1,000 by the
Yes.
year 2030.
Yes.
All right.
Yes.
And those at risk would be, if you're talking about the Thai context.
Actually, in Thailand, the more than 50% new infection occurs in among the key we call key affected populations. That is the transmission through the sex between males and also from sex workers to clients, and also clients to sex workers as well, and also people who inject drugs. But however, we also found about 20% coming from the partners, also partners of the key populations, and also partners of the general population.
Right. And how updated and educated are the population of Thailand regarding HIV infection and AIDS as a whole? Because it's so important to really know and understand, because then if you don't, then there's the stigma, then it's fearing of going out there and saying, I am HIV positive, etc. And that will hinder treatment and will really stop the process of reducing the overall numbers. So how open and how updated are Thais out there regarding the latest?
One challenge that we found, it seems to be people in Thailand always ask, do we still have people with new infection from HIV? So that's something that we have to go through. And like you said, when people afraid not to be like if they are positive, they are at risk, but they don't want to know that they are positive because they are afraid that they will be stigmatized and they will be get discrimination. So this is something that we have to make the public understanding all of this as well.
How do you go about doing that? What are the efforts being taken to reduce that stigmatization?
We try a lot not to have the collaboration. We have two kind of interventions. One is we call targeted interventions. So for that one, particularly for those at higher risk. So for that one, we do something. But the other interventions we do as the public things. But for this, I think we need a lot more of collaboration from the mass media or from the those working with the public media.
Spread the word,
Yeah,
perhaps
that's
social
right.
media, very far-reaching. Right. So what is key in terms of your efforts now overall?
Yeah, actually, when we talk about the country, if we would like to end AIDS, we have to do to achieve the coverage of the interventions. So it's a national scale So when we talk about the national scale, we have to talk about the policy. So we have we got a lot of efforts trying to convince the policy makers that we can end AIDS by this way. And then when the policy come up, the other important part is where we can get the money for. So this is the funding issues that we have to make sure that everything will be not only for 1 year, for 2 years, but it is a services provided to the people. But not only not policy and funding. We have money, we have the policy, but if at the implementation level, the service providers are not capable enough. So that's the other part that we have to build the capacity. And particularly for Thailand, I think we are clear that we have to work with the hard to reach people, populations. So working with the community is a key. Otherwise, we cannot reach them, and they are not able to reach the services.
So you've just highlighted some of the challenges and obstacles which have to be overcome. How hard is the government working in trying to overcome these issues, these challenges, such as lack of funding and staff heading out there to help spread out the word, or getting to the hard to reach areas, the remote areas?
Actually, I think the situation right now in Thailand, the policy has been cleared. They are very supportive to the programs. Looking at the funding, in Thailand, everyone who's positive, who get infection, they can be treated free of charge. There are some challenges with the migrants, but however, for Thai people, if they are positive, they will get infection. They will get treated free of charge. So for the policy, I think in Thailand right now we are quite get through. But our challenge is that because we have to reach the hard to reach population, and we need the collaboration with the community itself and also the civil society organizations. At this moment, we still have the limitation for the regulations, how to use the government budget to support the civil society organizations. But it's coming gradually good. But however, we need sustainable laws and regulations that help us to how to provide the support to the community to work together with the government. From the government side, I think we also need the motivation for the health service providers to provide, because if we have more people, and currently for those who are positive, they still need lifelong treatment. So the number of patients is like cumulative. So this. Another thing is the issue that we have to try to find a way how to make it, we call differentiated care, getting the patients, they don't have to come to the hospital every month or every 3 months. They can be transferred to the local at the health centers level, or even for some groups, we can build the capacity of the civil societies to help in taking care.
Okay. You mentioned that one chief obstacle was getting to the hard to reach areas. That's geographical, right? Are there any sort of certain groups who are stubborn and they don't want to receive treatment or be tested, or perhaps they don't even want to use, like religious reasons, they don't want to use their condoms, etc.? Because you do have that issue as well globally, whereby it's because due to religious reasons they're not going to use a condom, they're not going to practice things like that. Do we have issues like that in Thailand?
I think condom use in Thailand, it seems to be quite popular. But however, there are many reasons that why people don't use condoms. No?
Correct.
Or
yes. Yeah, for sure.
But that kind of things, I think the government also provide support the condoms to the people. But however, I must say that in Thailand, because we have enough information, strategic information, that we can we can make a plan to be focused in which area, in which populations, in parallel with the make understanding of the public. So this is something that we are moving on.
Right. Any final questions from you, Dr. Colby?
One question, because you said there's still 6,000 infections per year in Thailand, which is too many.
Yeah.
But if you look back 20 or 25 years ago, there was 160,000 infections
yeah, that's
per
right.
year. So actually, that's been more than a 95% decrease, which is, I think, a great success that Thailand has had, and maybe can be an example for other countries in the region and in the world. Do you have any sort of what were key elements to that success in Thailand that maybe other countries can learn from and emulate?
I think the group that working with the elimination of parents to child HIV transmission, that's a great success of the country. And I think this morning the presentation by one speaker talking about the starting actually from the Thai Red Cross initiative at the first moment as well. But however, I think from that's the very important to have the initiation. But then we don't stop at those initiation, but we scale up. I think the matter of the ending is the government is responsible for the scaling up of these services. Otherwise, it will not be able to go to end AIDS because it's project by project. That's right.
I think scaling up campaigns and projects is extremely important, and also what is key is to keeping them constant and to continually go out there, educate staffers or perhaps volunteers to head out there, educate people, and to really continue with the educational process and the training process so that we get the word out is extremely important as well. Any final words from you to our audience here? I think Thais and experts here in Thailand can be very, very proud because they've achieved so much over the years in regards to, I think, being a role model, because we're seeing, as you mentioned, the numbers have reduced a lot, and that's definitely something to be really proud of. Any final words for our viewers watching us live?
I think the goals of ending AIDS in Thailand is not only the goals of the Minister of Public Health, it's the goal of all Thai citizens. But we have to work with understanding the context of HIV. If we can normalize HIV, so everybody doesn't are not afraid to know that they are positive. Even they don't use condom. So if they are, so from that, everyone understands. So everyone access to testing, and then everyone after testing positive, there are access to the treatment, and then treatment you continue adherence to the treatment. So that will make not just only you yourself that positive, but also helping others, and then everyone. So I think my word is that ending AIDS is not the goal of anyone, but of everyone.
Definitely a concerted effort. Thank you so very much, Dr. Petchsri Sirinirund, consultant for the Ministry of Public Health here in Thailand. Thank you very much. Thank you. All right then. Now, we've learnt a lot, and that's a Thai context. Yes, we have to be really, really careful with these chairs here. We don't want any accidents happening here. We are now going to move on to the final topic for this interview session. We've got one more coming up later on at 2:30. But before that, the role of community workers. Once again, we're going to continue with Thailand. And we have with us Ms. Surang Janyam. She is going to join us here. So let's welcome Ms. Surang Janyam, the Director of the Service Workers in Group, or SWING. Am I saying that right? Is that SWING? Swadee ka.
That's right.
All right. Please join us here.
Thank
Take
you.
a seat here and let me just help you stabilize that chair.
Okay, thank you.
Thank you very much indeed for joining us, because your role is very, very important. Just now we heard from Dr. Petchsri, it takes not just one or two people to spread the word, to get things going and to help reduce the numbers, but it's instrumental that we all work together, government, public, private sectors, NGO, civil society, etc. So your role is extremely key as well. Once again, the role of community workers. Can you expand on that, please?
Yeah, if we look at we look back in the past, yes, when we heard about AIDS in Thailand, that is in that time that is not just only the responsibility of the Ministry of Public Health. We can see many of the NGO they come out that's okay to take responsibility of how we can support among each other to ending AIDS in Thailand since in the last 30 years ago. That we keep still continue to working together with the government. I would like to say that is, in Thailand, if we look at the role of the civil society or the community organization, we are quite very strong. We are quite very strong. We can see many of the success things in Thailand. This came from the power, the networking of the civil society. We put many of the issue that's okay. We are together, but the one thing that we are working, we did not okay. Try to to separate in two sides. That is this side is for the government, this side for the NGO. But we are collaborate.
Wow.
Together because we cannot let someone to do something alone. If we come together, that we have more idea to create the activity to serve the problem that we face in front what we are.
I was going to ask because I know your organization Swing is actually out there working in the community with people right today as we speak. So can you tell us what exactly is Swing doing in your service centers in the community?
Yeah, like Dr. Petchsri says, yes, okay, the sex worker, this is one of the hard to reach and the high risk population. Swing, that is we focus on the sex worker, every gender, male and female and transgender sex worker, because if we look at the evidence, that is okay, the sex worker, that is one of the group who have the high risk. That's not a lot of the group of the NGO or the committee to work with sex worker, because in Thailand sex workers still illegal and a lot of the stigmatized among the sex worker. And then we are the main organization in Thailand to work with sex worker. What we do, we try to empowerment the sex worker, to let them know, even you are the sex worker, you are very smart people. You can do something to support yourself. You can do something to support your community. And then the mainly now what we do, we focus on the HIV prevention, also the testing, and also the care. And okay, we can see the change what we are now. In the past, sex worker in the community, they are the client to get the service from the healthcare provider. Right now, Swing, after we start to do the community-related health service, and then we can come out from the client to be the service provider. We can educate our sex worker. We can do a testing by ourselves. We can do we can give the treatment by ourselves, and then we can do care support by ourselves. This is the role of Swing. We work with sex worker. We work with the community.
Okay. From your experience working with them, so you actually go to them and you make them know that Swing is there to facilitate and to help them, to guide them. That's right?
That's right.
And how open are they to you going in to assist them and to help them to make their lives better, if you will, too?
It's not easy.
It's not easy.
It's not easy for the first time because no one trusts. Because what I told you, that's it. They are the illegal. They have to protect themselves. Even the business owner or the sex worker themselves, they have to protect themselves. Not easy for them to trust someone.
Yes.
But for us, because most of our team, they are the people from the community. That's what I say. They are the sex worker in the past.
Correct.
And then we know the technique. because we speak the same language, we know what we want, what we like, and we don't like, and then we use that strategy to reach to them for make them believe and trust that we try to bring the good thing for them. We did not to make them a problem, and then we keep continue. We never make ourselves we are higher than them, but we think we are the equal. But we are friends. We want them to have a safe life. We want them to have a better life. And then we protect them, and then we always tell them, even you are a sex worker, you are human being.
Correct.
You have right.
You have your rights.
You have right to access to the healthcare service. You have right to access to the education as same as another people in the society. That's the role. That's when we do this way. Most of them they are very agree, and then they are very accept the activity what we try to provide with them.
So after you penetrate and educate them, they do make changes.
Many of them, they change a lot.
All right. So they're not stubborn. They are willing to accept these new ways, and they will make the changes to improve their lives.
Yeah, and also we can see the smile of them. Many of them they have a lot of problems. When the first time we see them, they are very close themselves. They don't want to talk with someone. They don't want to talk with us. And then after that, we keep trying to make them to know you are not lonely. You have a friend, we are friends with you, and a sister, and we are brother. Any problem you can tell us, not only the physical, not only the HIV/AIDS. Any the problem. We ready to listen for you, and then if we can support you, we can do it. We can see many of them they smile, and then they're very happy, and then they tell another friend. From the service what we are provide, and then they bring another friend to come to get a service what we are doing.
That's very, very effective indeed. So they will go for their tests?
Yes. Many of them they go to the test. We do a testing. What we told you, we do the community-led health service. And then we have our own clinic in our drop-in center. Our drop-in center in Pat Pong.
How convenient.
Yes. If they want to come to get a test in the drop-in center, they can come. And then if they don't feel comfortable because they have to work, and then we move to them. We have the mobile to do a testing for them. And then if they are HIV positive, we have the care support team to take care of them, to make them feel you are not lonely. You have a friend who we support you. Whatever that's.
So really, really facilitating and making it easy for people, easy access. Pat Pong is the red light district here in Thailand, and they have a center there, so they don't have to travel too far at all. All right. Now, once they have been tested and say the test comes out positive, how are they when it comes to treatment? Are they willing?
Not easy, because it's the stigma type of the positive case. Like if they are sex worker and they are positive, like they have the double stigma, because right now, who are even the general people, they are HIV positive. They already have the stigma. But if they are get the HIV from selling sex, that means they have the double stigma. Many of the business, business owner, they will not allow the sex worker who are positive to work. That's when they know the status, they know that they are the positive. They are afraid that they will lose the job. More than that, they are afraid that they are afraid that they are positive. If they say if they come to get the treatment, if someone see that they have a pill, they have ART pill. Maybe if the business owner know that they are positive, they
will be sacked, let go.
Lose a job. That's because being sex worker, most of them did a last job for them to earn the money, to serve the life, to serve the family. If they lose a job,
what happens? It, isn't
that is a big challenge for us, but we try to educate them. Even you are positive, and then we try to educate the business owner also. Even your worker is positive, they can
continue to provide services.
Yes, that's right. And then please take care of them, because when they are still healthy, before they are HIV positive, they earn a lot of money to support your business. Why not? When they are positive, you will not support them. We work very closely with the business owner also to try to change the attitude. Very important indeed.
Ms. Surang, you are providing such useful, interesting information right here, but unfortunately we have run out of time. Maybe we can bring you back later on, because we are going to continue with our live interview sessions for the next 2-3 days of this conference here. It's the 19th Bangkok International Symposium on HIV medicine. Thank you very much indeed.
Thank you very much.
And thank you very
Thank
much
you.
to you as well, Dr. Donn Colby, for helping me out here. Thank you very much to the viewers. We will be back with you again at 2:30. We will begin with the final session, and topics we'll be covering will be how to implement prevention, meet the experts. We'll also be talking about STIs, sexually transmitted infection screening, as well as management. So join us then at 2:30. For now, bye-bye. สวัสดีค่ะ